You can get this in the question. They may tell you, they may say there's pain with range of motion. They may say they have a positive grind. And what a positive grind is when you take the big toe and you push it axially into the metatarsal and see whether they have pain in the middle of their range of motion there. Second question, is there instability at the first TMT? And we'll look at a photo of that. Third, is that first MTP congruent? And that's the idea we just looked at of whether those joint surfaces match up or not. And then finally, how do all those angles contribute to the decision of what kind of osteotomy you want to do? So this is what hypermobility is going to look like. You can see that the first tarsometatarsal joint is gapped plantarly and that there's instability there. And then you can similarly see that it's non-congruent when you look at that AP X-ray down at the bottom of that slide. You can also get a clue that there's instability if you have second tarsometatarsal arthritis. There's that gapping. All right, so going through an algorithm as best I could put it on one slide. Is there arthritis present? If yes, if it's at the MTP, easy. You do a first MTP arthrodesis. And there's other reasons that you want to do an arthrodesis if you have instability and pain and things such as CPRA or sometimes even in gout. Second, or with the first question, if that arthritis is present at the TMT rather than at the MTP, then you also fuse, except you're fusing that first TMT, also known as a Lapidus procedure. If there's no arthritis, then you're going to ask yourself question number 2. Is that first TMT joint hypermobile? If it is, sweet, you do a Lapidus or at first TMT arthrodesis. If it's not hypermobile, then you're going to do a soft tissue release, which I'll show in a second, and a combination of any of these ones that we're going to go through. So everything from here out usually has a soft tissue release. So then you ask question number 3, if your first TMT isn't hypermobile. Is it congruent? If the answer is yes, then you're going to do a medial closing wedge or some kind of biplanar osteotomy to not interfere with that congruent joint. If the joint is not congruent, which is most of the time in hallux valgus, if it's not a juvenile case, this is when you start to measure those pesky angles. So the first angle you want to measure is the intermetatarsal angle. Is the hallux valgus coming from the middle of the foot, or is it something that is only going on in the forefoot? If that IMA is bigger than 15 or 16, and again, these are approximate, then you are going to do a proximal osteotomy because that's where the problem's coming from. You can fix the bunion at the MTP all day long, but unless you fix that splay at the first and second tarsometatarsal joints, that bunion is just going to recur. Or your other option, if you have gapping at the intermetatarsal angle, is to do a Lapidus and to fuse. All right, if you have a big IMA proximally and they also give you a huge HVA greater than 40, sometimes 35 to 40, then you're also going to do a distal osteotomy. So the answer would be a proximal and distal osteotomy. Okay, so what if your IMA is less than 15 degrees? Then you look at your HVA. Is it a big HVA or is it a little HVA? If the HVA is big, then you're going to do a distal osteotomy, often a chevron or a scarf, which has a little bit more power, and I'll show those in a second. If it's a small, then you're just going to stick with a chevron. All right, and then this is another algorithm with some more specific angles that you can also come back to. And again, this is just for non-congruent joints. If it is congruent, you're going to do a medial closing wedge or a biplanar osteotomy. So these are the various surgical procedures. The scarf that I was talking about earlier sort of cuts a Z laterally in the toe, which you can see there. What's the soft tissue release or a modified McBride? Again, you never do this without an osteotomy. That's always the wrong answer if it's isolated. What you're doing is releasing the joint capsule so you can push that toe over. You're cutting the adductor, and you're also cutting the transverse metatarsal ligament. All right, so some questions. This is a 19-year-old with chronic hallux valgus, and also pay attention to the fact that this patient is 19. There's tenderness over the medial eminence. normal range of motion. She's failed all of these modalities. She has a HVA of 34 and an intermetatarsal angle of 16. So in addition to some form of proximal correction, what should they do distally? So let's blow up that distal picture. You have to ask yourself, is there arthritis? No. Is it unstable? No. Is it congruent? So let's go through that. And this does look like a congruent joint, right? There's that joint surface on the MTP, and it's aligning well with the phalanx. And that's just to show you the normal or the perpendicular. All right, so is arthritis present? No. Is it hypermobile? No. And again, often they'll show you that lateral X-ray if they want to show you a hypermobile first MTP or TMT rather. So you're gonna do a soft tissue release and then some kind of medial closing wedge or biplanar osteotomy because you have that congruent MTP and you don't want to mess it up. You want to keep it congruent. So you're going to do the proximal osteotomy for that IMA of 16 and then add a medial base closing wedge osteotomy because you want to keep the congruence. Question number 2. So this is a 32-year-old who has pain. The intermetatarsal angle is 17. What is the most appropriate surgical treatment? So looking at that a little more, is there arthritis? No. Is it hypermobile? That joint looks congruent on the AP. They don't give you lateral, so probably not. Is it congruent? No, those joint surfaces don't align anymore. So you're going to ask yourself, what is the IMA? Okay, well, it's bigger than 15. And so that becomes just a proximal osteotomy. And then again, we're adding all those osteotomies usually to a distal soft tissue release. So what are the complications? Undercorrecting and recurrence are one of the biggest complications of hallux valgus surgery. We dread them in juvenile bunions because it's almost guaranteed over the life of that patient that they're going to get some kind of recurrence. And then you also have to really understand the bunion and do the correct surgery for the correct deformity. When you're talking about those TMTs, TMT fusions or the Lapidus surgeries, you want to keep in mind that you're taking away bones. So you're going to shorten that first ray. And when you do that, those second and third MTPs are kind of hung out to dry, and those can get overload, otherwise known as transfer metatarsalgia, and that can become painful. So sometimes we go ahead and shorten the second or the third metatarsals when we do a Lapidus. That shortens the foot a lot. And then finally, they love to test on the medial dorsocutaneous nerve, which can get pulled around during various surgeries, and you can have numbness there, or you can cut it if you're not being careful. And then finally, you can have hallux varus if you really overdo it with that medial eminence resection. Fibular sesamoid resection risks hallux varus. And then if you overcorrect, of course, you can get that as well. All right, so going on to hallux rigidus. So arthritis of the first MTP joint is the same thing as hallux rigidus, just a fancy name. It's a very, very common form of arthritis. Females more than males, similar to bunions, and it can be associated with some inflammatory conditions. How do we treat it? Conservatively, basically, we add rigidity, usually with either a Morton's extension or a carbon fiber plate. You can also do a steroid injection into the first MTP. What you need to look for in the question stem is where do they have range of motion when they describe the exam. If they have range of motion only at the end of dorsiflexion, then chylectomy, or plantar flexion, basically at the end range of motion. If they have pain through the middle of their motion, then they want you to fuse. You're going to offer them a first MTP fusion. If in the question stem they make some really big deal about the flexibility of the toe being super important, then you can do a synthetic cartilage implant, or you can do an interposition of soft tissue. So this is a chylectomy. It's basically taking off those dorsal bone spurs to allow for better range of motion. So you're going to do that with pain only at the end range of motion. If they have pain in the mid-range, you're going to do an MTP arthrodesis. These tend to heal fairly well. Patients tend to be very happy. If you have a arthrodesis or you have a surgery like a arthroplasty where you had a lot of bone that's missing, and you need to revise it, then you basically do a bone block arthrodesis, putting in some bone graft in between the bone that you have left, and then you fuse it. So that's a interposition there, or not an interposition, but a bone block arthrodesis right there. Other things that you can do are to sort of loosen up the joint is a Moberg, where you dorsiflex that proximal phalanx to give it some more mobility in combination with the chylectomy. And then a Keller is almost always a distractor. That's usually just for elderly, super, super low demand people. So we have a 34-year-old man with chronic great toe pain. He's a big guy. He had surgery 8 months ago, and he is really uncomfortable. So you can see that he is very narrowed. He has lots of pain. Because you have bone loss due to the arthroplasty, you are going to do an arthrodesis with structural bone graft. Okay. All right, 55-year-old man who has worsening pain and dysfunction. I know the pictures are really small, but just take my word for it. He has arthritis. What type of motion is typically impaired? The answer is dorsiflexion. Dorsiflexion much more commonly than plantar flexion. So they're asking here, what is the advantage of interposition arthroplasty with a synthetic cartilage implant? And believe it or not, it's just decreased surgical time. You'd think the answer might be restoration of normal range of motion, but even with an interposition not fusing, these patients tend to still be pretty stiff. And finally, we have a 58-year-old man. He describes pinching pain when running or walking. He has tenderness over the first MTP. He has limited dorsiflexion of 40 degrees on the affected side compared to 75 on the other side. He's failed conservative management. What are you going to do? So because he has pain only at the end range of motion, you are going to do just a chylectomy. All right, so fifth, metatarsal fractures. There are 3 zones. They all fracture slightly differently. So zone 1 is the most common. It's gonna happen in a plantar flexed inversion mechanism. In zone 2, you're gonna do that through forefoot adduction, and then zone 3 tends to be due to repetitive microtrauma, sometimes in conjunction with a foot deformity. So symptoms are going to be pain, obviously. Look for the varus hindfoot or cable varus deformity that can predispose somebody to injury. Look for lateral ligamentous instability, which can also go with cavus. And then finally, pain with resisted inversion, because you got to remember that that brevis tendon does insert on the base of the fifth. So for a zone 1 fracture, it's basically protected weight bearing. These almost all heal, and even when they heal with the fibrous union, these tend to be not symptomatic, but sometimes these seem like they take forever to go away, but they almost always get better without any treatment. In zone 2, because this is in a vascular watershed region, the non-union or refracture rate is fairly high. It's about 33%. On the test, though, unless they give you an elite athlete or a college athlete, you're still going to treat it non-weight bearing for 6 to 8 weeks. If they do want you to operate, then you're going to usually fix with a solid screw, sometimes a cannulated screw, though. And then non-weight bearing for 6 to 8 weeks is the treatment in zone 3 fractures. These are going to be because of chronic stress, usually from a cavus foot deformity. Similar to zone 2 fractures, these can be treated non-weight bearing for 6 to 8 weeks unless you have an elite athlete, and that's when you're going to go ahead and pull the trigger on an ORIF. So surgical considerations, remember the non-union risks with zone 2 and 3, make sure you check their biology. Sometimes they'll test you on screw diameter. Never pick the screws that are less than 4.5 millimeters. Those aren't rigid enough. And then what causes failure? Putting that athlete back into the game too early. And then finally, if you use a long screw that is a straight, screws are obviously straight, but you're putting it into a curvy bone, sometimes that can distract the fracture. So make sure your screw isn't too long. All right, and then some rapid fire foot trauma. Liz Franks, axial load through a hyperplanar flex foot. You get the classic plantar ecchymosis, localized tenderness. Uh, the thing that you need to remember for test taking purposes is that they want you to distinguish between ligamentous and non-ligamentous injuries. So if there's a ligamentous injury, they want you to fuse. Similarly, if there's a flex sign, meaning a little avulsion of the Lisfranc, you need to fuse. And then fractures that are also equally unstable, in addition to a Lisfranc, if you see multiple proximal metatarsal fractures, you're going to infer that instability and treat it like a Lisfranc. So there's a 19-year-old man who was involved in a high-speed collision 6 months ago. He continues to have localized pain. What's the next best step? You can see that his Lisfranc interval is widened there, and he's continued to be in pain. Ligamentous equals fusion, so you're going to pick choice 5, ORIF, or sorry, not ORIF, but open reduction and primary midfoot arthrodesis. So when they ask you about differences in outcomes between ORIF and fusion, basically they're equivalent, but sometimes they want you to think about cost. So with an ORIF, you have to take out the hardware. That can increase cost, and if they sort of exclude hardware removal from those like complications heading, then basically there's no difference in complications. But you do remember have to take out hardware in the ORIFs. So compared with ORIF, the treatment of Lisfranc, primary arthrodesis has a lower cost of treatment because, again, you don't need to go in and take out hardware. So 58-year-old, pain and swelling in the midfoot. She has diffuse midfoot swelling. They ask, what advantage has been demonstrated for treatment of this injury with primary arthrodesis rather than ORIF? And again, that lower weight of hardware removal is going to be true every time. And then finally, what foot deformity is associated with Lisfranc, and this is something you just have to know. It's planovalgus deformity. All right, talus fractures. So this is an axial load with forced dorsiflexion. These all need to be emergently reduced. For type 1 non-displaced fractures, you cast for 8 to 12 weeks. As the degree of peritalar dislocation worsens, the risk of AVN gets worse. So when you see talus fracture, you immediately think, oh my God, osteonecrosis, Hawkins sign. But you need to remember that subtalar arthritis is actually the most common complication of this fracture, also significant amount of ankle arthritis. Osteonecrosis, it's 30% incidence overall. Remember, it goes way, way up with the Hawkins 3 and Hawkins 4s. What is that Hawkins sign? It basically indicates intact vasculature because it starts resorbing bone just under that chondral surface. And you'll see that subchondral lucency about 6 to 8 week post-op. And these, you don't get increased osteonecrosis by delaying internal fixation. Sometimes you just have to wait. And then finally, you want to be careful about varus malunion, because if you have a varus talus, that locks your hindfoot, and you're unable to let the lateral part of the foot accommodate to uneven ground. You're basically walking on the side of your foot, and patients don't like that very much. How do you reduce varus malunion? Do an anatomic reduction, obviously, but also using mini frag plates for comminuted fractures can be helpful in avoiding that, as well as 2 incision surgery, both a medial and a lateral incision. So you see this fracture in the emergency room. This is after they tried reducing it. What do you need to do? You need to take this patient and do a closed reduction under anesthesia. It is emergent. So this is a 40-year-old who missed a jump from a motorbike. What is the most common complication? I know you want to say osteonecrosis, but remember, subtalar arthritis is the most common complication. And then finally, delayed ORIF of a displaced talar neck fracture in an adult has been associated with what rates? Associated with decreased rates of what complication? And that is infection. And similar to calcs, dislocations, you need to reduce it emergently, but you need to allow for the soft tissues. All right, so calcaneus fractures. You could talk about these for days, but some quick important points they like to test on. Losing Bowler's angle is a bad thing because you get anterior impingement when that talus isn't on a downward slope. How do you fix these? You do a bone block arthrodesis. So you get that lamina spreader in there, jack it back up to appropriate height, stick a piece of bone in there, and then fix it with the screw. Second, the FHL, it runs under the sustentaculum, also known as the constant fragment. Don't put a screw in it because you can sever your FHL or at least end up with pain with toe flexion. And then finally, there are many, many factors associated with poor outcomes. These are sort of facts you just have to memorize. Some highlights are that people older than 50 have similar outcomes with surgical and non-surgical treatment. Bowler's angle is important. The lower the bowler's angle, the more it was likely a high energy injury and therefore more trauma is absorbed in the soft tissues. And then finally, men tend to do worse than women in terms of surgery. So you see this image. When the patient comes in, what do? You need to do emergent surgical intervention for that and get that reduced in order to prevent skin compromise. All right, this is the lateral and axial radiograph of a 4-year-old who fell 10 feet. What is the most common acute concurrent pathology? And this is just something you have to run into, and that's peroneal tendon dislocation. As you know, the peroneal tubercle is along the lateral side of the calc, and so those tendons can get dislocated if the calc gets shortened and you have comminution there. All right, syndesmosis. Syndesmotic ligaments. As you see here, these slides are from the resident lectures, which I highly recommend in terms of the dissections on them. I wish I would have seen these in residency. I might have understood things better. Here are the syndesmotic ligaments from the back. So the take-home point here is when you have a bony fracture where a ligament is attached, then you can have a unstable syndesmosis. So for example, you have this posterior malleolus fracture, and they're asking why could there be syndesmotic instability? Like, why does reducing this fracture improve the syndesmotic stability? And the answer is because the PITFL, or the posterior inferior tibiofibular ligament, inserts there. So that's why a lot of us like to fix those posterior malfractures, even if they're on the smaller side. It's to increase that syndesmotic stability. And there's a bigger shot of it. All right, finally, foot puncture wounds. No questions on this that I could find, but the 2 take-home points. The most common soft tissue infection is staph. The most common cause of osteomyelitis is Pseudomonas. So again, we tend to think of Pseudomonas immediately when we hear puncture wound, but that only pertains to osteomyelitis. Staph aureus is the most common soft tissue Staph aureus is most common cause of soft tissue infection. And those are my kids. Thank you.
Thanks, Laura. That was intense, but thanks for going through all these topics. And we just have one question
Yes.
from Sir. In regards to test-taking strategy, what qualifies as elite athlete?
Elite athlete, often they'll just say that. Like, they'll come right out and say the words elite athlete. Maybe somebody who's like an ultra marathoner or somebody who's competing in Ironmans, they'll hopefully make it pretty obvious that even if it's an amateur, it's somebody who, they're just talented at it, I guess. But sometimes they'll say like professional, et cetera, et cetera, et cetera. Either that or collegiate. So good question.
Yeah, I think they're going to make it clear in the stem of the question that either point you to that this is a professional, whether they're going to just blatantly say the word or they're going to make it obvious. But other than that, like Laura said, it's going to be the normal weekend warriors, and all of those like zone 2 fractures are going to be treated non-operatively. Alrighty, we're going to hand it over to Pierce. I'm going to ask you to start sharing your screen.
Oh, and I will stop sharing.
All right, can everybody see that? We'll go ahead and get going here. So my name is Pierce Seabaugh. I'm an attending orthopedic surgeon at the Jewett Orthopedic Institute in Orlando, Florida. I'm going to go over some different topics here: anatomy, some of the arthroscopy-based questions, as well as focusing on ankle arthritis. So I don't really have anything to disclose regarding the anatomy. Most of the stuff, or at least question sources, circles around really the MRI based portions of the anatomy, some perineal pathology that I've kind of roped into anatomy. Ankle arthroscopy is almost like anatomy questions. A lot of it is nerve injury based. We'll go through that, and then we'll touch on a couple areas of ankle arthritis and do some questions here. So anatomy, like we said, questions center around dorsal sensory and foot and muscle motor innervation as well as MRI. So you've got to know not just where the SPN lies, but some specific areas that it lies in branches wise. So there's been previous questions regarding the dorsal medial cutaneous nerve for bunions, as well as it touching the second dorsal web space, not just a deep perineal nerve innervation area, and then also its intermediate and lateral based branches that you can kind of see in this picture. As far as the motor nerves are concerned, you'll get a lot of questions on medial and lateral plantar nerves. So I would suggest just rote memorization. What they're going to do is they're going to talk about a certain nerve being pushed on. They're going to tell you the sensory distribution relatively in a tibial nerve sense, but then they're going to ask you which muscle does this innervate. Really the one I think if you're going to get nailed on one of the plantar nerves, it's going to be probably asking you about Baxter's nerve, what it innervates, and if they really want to come after you, they're going to go and ask you where the nerve lies between. It's in between quadratus plantae and flexor digitorum brevis. So once again, this is anatomy stuff. There's really nothing to be taught here as much as it is rote memorization. So here, anatomy, I think there can be a little bit better teaching. I do apologize for these images. They're kind of flip-flopped to a certain extent, but this is probably one of the most important images you can look at for foot and ankle OIT. There's at least 2 questions every year with the MRI being thrown up, and they're going to ask you, what is this, essentially, in some roundabout way. So they've asked where the sural nerve is previously. You need to know that the lesser saphenous runs with it. They're going to ask about your relationship of your perineal tendons. Remember, brevis to bone, and they're also going to ask you possibly where their relation is in the foot. Whether brevis being dorsal to longus as you move through. So, and then obviously you need to know where your tendons lie on the medial aspect of the ankle. So Tom, Dick, and very nervous area as well. So perineal tendons, this is just we're going to go through these really quick, kind of give you a cookbook for answering questions here at the end. So we talked about the anatomy. Something that has shown up on recent OITEs has been questions actually with an os perineum in it. So that is one of the foot ossicles that's actually found within the peroneus longus. It's usually lateral to the cuboid. You can see it oftentimes on the oblique film. So keep an eye out for this. We'll go through a tricky question here in a bit that kind of shows why that's important. The SPR has been asked previously before. Remember, it retains attendance in the retromalleolar groove. You may see a flex sign on the x-ray or on the MRI. Like I said, going back to that very important MRI, the subluxation of the tendons kind of rolling around the fibula there, and you're going to get question stems of pain and instability. And then tendon tears on the MRI. These can be actually tough to see and discern, and I'd say sometimes those questions are borderline whether they actually contain a quality image. But usually there's a split of one tendon, and you got to also be mindful that this may be in a question stem with either a cava varus foot, somebody who's placing stress on their lateral ankle in a chronic nature, or chronic ankle sprains. So here's kind of our cookbook. So acute SPR, tendon tear subluxation with tendon tear in an athlete. So fix the SPR, repair the tendon, and groove deepening is always the plus minus. Do you do it? Do you not? I mean, it would have to be here, I would suggest, really, really obvious on the MRI that it's a convex groove, whether you need to deepen the groove. I doubt you'll be asked on that. A non-athlete, that has not been treated yet, immobilization for 6 weeks. Chronic recalcitrant, fixes if they're an athlete. Tendon tears, less than 50% of the tendon that is torn when you get in there, you repair it. Single tendon tear greater than 50%, resect torn portion and transfer proximal distal healthy ends. Both tendons greater than 50% with maintained muscular excursion. That's important. You can do an allograft reconstruction, typically of just your brevis tendon. If both tendons are torn very badly with no excursion, you do an FHL transfer. Remember, any of these revision situations, this would be an unlikely question, but something just to know. If they've got a foot imbalance, usually a cava varus foot, and it's a revision situation, and sometimes even in a primary situation, you may want to consider balancing their foot while doing this procedure. So onward to ankle arthroscopy. This is a little bit more straightforward. Usually these questions are portal based. So first portal made, medial portal. This is just medial tibialis anterior. That has even been a question. What is most likely injured? Your tibant, even though you generally can feel it quite well. Second portal is established under usually some degree of direct visualization, right? So you take your arthroscope and you place it relatively anterior so you can somewhat see the neurovascular structures on the anterolateral aspect of the ankle. You should also mark your SPN prior to beginning the surgery. And you can do that by kind of rolling it with your hemostat with the foot complete plantar flexion, and then using good technique they may even ask about, which is a nick and spread type technique. So as far as arthroscopy is concerned, with posterior arthroscopy, I haven't seen this yet from what I can find, but this is becoming increasingly popular, certainly for osteogonum removal, addressing the FHL pathology, oftentimes even subtalar fusions or posteriorly based osteochondral lesions. So setting up these portals is based off the tip of the fibula. Basically draw this around and hug the Achilles. Once you're in, your entire job really is to stay lateral to the FHL. So I'm not sure if you all see this, but just in case. So on to ankle arthritis. Just a little bit of background. Once again, this is a lot of rote memorization type stuff, but ankle arthritis is quite a bit different, not nearly as common, and 2/3 posterior or post-traumatic, as you all know. So on the OIT, as with most things, it's not always operate. Usually, if they've not had some degree of non-operative treatment that's significant in a situation like ankle arthritis, you're going to pick non-operative treatment. Even if it's terrible-looking arthritis, still pick non-operative treatment. So NSAIDs, bracing, so in Arizona or gauntlet braces, it's been referred to previously, with rocker bottom shoes and activity modifications. And OrthoBullets has some pretty nice pictures of rocker bottom shoes, at least some old school ones, but they may show you a different kind of shoe as well. So surgeries that you're not going to get questions on, and I'm put these in here because this is not going to be the answer on the OIT. I can almost guarantee you that. Is some kind of arthroscopic or open debridement and exostectomy, unless it's like directly related to a very small osteophyte in like an athlete who's got a dorsal impingement type thing. You will not see full-blown ankle arthritis. So ankle arthritis, that is not the answer. Distraction arthroplasty, while it's still done, not the answer. Supramalleolar osteotomy could possibly be the answer in what we call a congruent varus ankle arthritis. So that would be somebody whose talus and their tibial joint lines are still in alignment. You don't have any tilting of the talus one way or the other, so it's some degree of, more than likely, a varus deformity through the distal tibia. This would be a young person with just a smidge of arthritis in the anterior medial shoulder that you may see in some degree of congruent nature, and that would be the reason for that answer. But I highly doubt you're going to see that, because that's somewhat challenging and remains controversial. So for Taylor OCLs, A little bit of background on that. Medially based OCL is not usually associated with trauma, but they're usually big and they're usually pretty deep. Laterally based ones are usually associated with trauma, usually superficial and small. So the question stem you're going to get for an OCL that may be tough to identify if they're not going to give you an MRI where it's obvious is a non-healing ankle sprain. So take a close look on plain films if you see this in the question stem and there's not a lot of instability like pain, and they've already done a lot of physical therapy. So treatment, chronic ones, less than 1 centimeter squared, essentially no bone attached to the cartilage cap, debridement and microfracture. If you got an intact cartilage cap, even if it's less than 1 centimeter, if you've got a nice quality cartilage cap, you should probably consider retrograde drilling with some degree of bone grafting. Large ones that are displaced or large shoulder lesions, ACI, OATS, or if it's huge, even a bulk hemitalar allograft. So moving on to kind of traditional ankle arthritis questions, we're going to try and suss out, when you need to be picking ankle fusion and when you need to be picking total ankle replacement. Sorry, let me bounce back real quick. So ankle arthrodesis, the patient you're going to hear for ankle arthrodesis is often young, often a laborer, okay, maybe a degree of Taylor AVN. They're going to have some level of significant deformity more than likely. So they're going to really try and sell and push, we're looking at ankle arthrodesis, or obviously if you've got a failed total ankle replacement, and this is not just going to be oftentimes an ankle arthrodesis, it's usually a TTC fusion. So another question they've done before has been the positioning of this. So you guys need to memorize, we're in neutral as far as the sagittal plane is concerned, slight valgus, slight external rotation, slight posterior translation, okay? Some of these other questions here have been, I haven't seen them in the past 3 or 4 years, but if you look way back when, 7 or so years ago, they've asked about union rates. So greatest persistent non-union risk is neuropathy. A lot of these patients have radiographic signs of osteoarthritis in other joints, so subtalar joint, talonavicular joint at 10 years. It doesn't mean they're clinically painful there. So other risk factors for failure, prior fusion failure, obviously, smokers, diabetics, avascular necrosis, or even adjacent joint fusion. So it's tough to get an ankle to fuse if you're trying to do that above a subtalar joint fusion. So finally, we've got our total ankle replacement section, or TAR for short. So when are you answering total ankle replacement on the OIT? So I'm going to tell you that it's older, lower demand. They'll still say there's some degree of active, but they're not going to be like a marathon runner. So low demand is relative. They're not going to be a couch to fridge type patient. No comorbidities, very little malalignment. There can be some, and there's been recent questions with true malalignment and normal BMI. And when I say normal, I just don't mean very high BMI. And no previous soft tissue issues. So they're not going to have you go through somebody with tremendous scarring or anything like that. So who's definitely not getting a total ankle replacement? Charcot. You're definitely not doing it there. Any degree of neuropathy, and they'll say advanced neuropathy typically in the question stem, vasculopathy or AVN. So why do a TAR? I mean, I've not seen this question. Actually, I take that back. There's been one recent question on this, and it was as far as improved gait speed and stride length, but also improved performance on uneven service. So you may see that question repeated. Complications you're going to see of total ankle replacements. Osteolysis has been shown as a recent question. So for that, CT with metal reduction type protocols, same type things you're going to get for a lot of joints questions. Subsidence. If it has not been worked up for a prosthetic joint infection or PJI, you need to do this first. If it has and you're ready to operate, typically that's a TTC. You're not going to pick revision total ankle at this point in time. Maybe in 5 years that'll be an OIT choice, or an accurate one. But at this point, in terms of the boards, no matter what you see in residency, it's not the right choice right now. So wound dehiscence, obviously, this is more with your anterior-based approaches. Certainly any post-traumatics, anybody who's got a flap, et cetera, et cetera. Medial malfracture, so prophylactic pinning is something that's often done. This has been an older question, plus 5 years out, but to prophylactically fix that, you'll pin it beforehand and possibly even place screws. So you may also see this as a complication post-operatively. So they begin weight bearing 4 weeks out of their total ankle arthroplasty, come in, and their medial mal is very swollen and painful to the touch, and you don't see much on x-ray. Well, you need to get a CT. They probably have medial malfracture. And unlike you may say with other joints questions where you can put a cement spacer, come back, and reimplant with a revision for hip or knee, that is not the answer in total ankle yet. So, questions. All right. What is the attachment site of the structure outlined and marked by the arrow in figure 1? So, like I said, even though this is in a previous question, the MRI maybe subpar. They probably could have picked a better cut of your perineals here. So it's your perineus longus. So once again, they're asking you anatomy. It's a secondary question. It's not like this is brevis or longus. It is, where does this attach? And then we've got figures 1 and 2, AP and lateral radiographs, 60-year-old man, history of progressive ankle pain, non-surgical management has failed. So what patient characteristic is an indication for recommending arthrodesis rather than arthroplasty? And so obviously you wouldn't do anything with an intra-articular infection. Ipsilateral hindfoot arthritis for a lot of people is actually a recommendation for arthroplasty, not arthrodesis. So it leaves neuropathy and talar AVN. And I should have been more specific here in the question stem, it's actually focal AVN of the talus or advanced peripheral neuropathy. So either one of those are good answers, which is the better answer. With these descriptors, it's advanced peripheral neuropathy. So 67-year-old woman feels a snap in the arch of her foot while walking in the grocery store. Previous injections for TMT, NC arthritis, still having problems and pain. They're showing you these 2 radiographs and which one provides the definitive diagnosis of injury. Really, this is a difficult question just going off of the radiographs. This is a process of elimination, right? So really they're giving you the top 4 images. So right away you can say, well, I'm not sure if I have enough information there to call a Lisfranc rupture. It looks pretty reasonable to me. Going down to a spring ligament rupture, you're going to see way more abduction through the TN with possible plantar flexion of the talus, which you don't have a lateral, so it's probably not that. Then you're going to see something pretty similar for a post-tip tendon rupture, right? So the pretty typical deformities for those. So it's perineus longus rupture, but I'm going to draw y'all's attention once again to that little os perineum just lateral to the cuboid. You can see in the picture on the right-hand side how it's retracted a little bit due to the rupture. So that's our answer here. So figure 4, figures 1 through 4, standing radiographs here, basically 72-year-old guy, chronic medial ankle pain refractory to surgical treatment. States his foot's gotten flatter despite orthotics, a lot of pain around the joint line, but a flexible, supple hindfoot. He can also generate painless inversion strength against resistance, but cannot perform a single leg heel rise because of ankle pain. So what are you going to do here? This is a harder question for a couple reasons. So he has essentially valgus ankle arthritis, but his foot underneath his ankle is reasonably well aligned. So once again, we're going through the answers. Flat foot reconstruction, that's not helping his ankle. Unless we're doing some degree of a deltoid reconstruction with it, and he's already got arthritis, so that's not exactly what we want to be doing. Triple does nothing to necessarily help his ankle, and his foot's already pretty well reasonably aligned. So that brings us to pantalar arthrodesis and TAR. He has very little pain in his hind foot, and it's flexible and supple. Probably don't want to give him a quote unquote peg leg, so to speak. So in this instance, healthy, active 72-year-old guy, even though he's got a deformity at his ankle, the ankle here, or the answer choice here is actually ankle arthroplasty. So make sure you're working through all your choices and doing some rule outs here. All right, some easier and faster stuff. Sensory loss distribution, dorsal-medial cutaneous nerve, potential complication of bunion surgery, terminal branch of, we talked about it, SPN. 65-year-old man visits your clinic 10 years after an ankle fusion. He's having to hyperextend his knee to ambulate. What is the malposition here? So we talked about what is the correct position. 5 degrees, that's correct. 7 degrees, probably a little too much valgus, not terrible. 12 degrees of plantar flexion, that's a lot. And then 5 millimeters of posterior translation, that's okay. So once again, he's too plantar flex, that's why he's hyperextending his knee to clear his foot from the ground. So what structure is greatest at risk during the establishment of the first portal and standard ankle scopes? We talked about this too. It's our tib-ant. So don't get tripped up on the SPN. Lateral portal, second portal for the SPN. Relationship of brevis to longus at the perineal tubercle. Perineal tubercle is on the lateral wall of your calcaneus for you younger residents. So we talked about that. Also dorsal, don't get tripped up. All right, 71-year-old man presents 10 years after a total ankle replacement. He had a wound dehiscence at the time that required a flap, but he's 10 years out. Okay, so workup for infection, also negative. What is the most appropriate surgical treatment? All right, on CT scan, what do we have here? We got a lot of cysts in the tibia. We got even more of them in the talus. We also have some subtalar joint arthritis. All right, so are we going to revise his TAR alone? Once again, this is OIT. Doesn't matter what you see in residency. You got to think towards the question. Okay, probably not. 2-stage revision TAR, still probably not. Tibiotalar arthrodesis. Well, in some ankle arthroplasty failures, you could just try and fuse the ankle, but we've got subtalar arthritis and a lot of bone loss. So probably not the deal here. And then, so we've got TTC arthrodesis is our last choice, and that is a choice. Most people did pick that. So healthy 45-year-old laborer, painful, rigid varus ankle arthritis with a 17-degree varus deformity. In case you want to do a takedown arthroplasty in the future, what approach should you use? Okay, so you've got direct anterior, arthroscopic arthrodesis, lateral transfibular, or mini open anterior. Usually lateral transfibular can have some degree of risk of fibular non-union, fibular malunion, and just not ideal for placing an incision there and then going back and doing an ankle arthroplasty unless you were going to do a Zimmer Biomet trabecular metal one, which is too much for this talk. So the other choice is mini and open anterior could possibly be an answer, but his deformity is 17 degrees of varus. That's going to be challenging to correct through a mini open. Same thing with arthroscopic arthrodesis. Still possible to do a total ankle after doing one of those as long as you don't extend your arthroscopic portals very far. However, 17 degrees of varus, probably not going to be able to correct that deformity through a scope. So we go back to our direct anterior approach. And that is the answer. So these are just some references that you can see. And
thanks, Pierce.
that is it from me.
We just have one question from Canon. For FHL transfer to peroneal tendons, do you approach both the peroneus longus and peroneus brevis?
I doubt you're going to get that question asked you, but typically you just are taking your FHL and tacking it into your brevis, and you're letting your longus fly. So you can do a pulver taft weave into the brevis and also dock it into your fifth metatarsal base at the same time, kind of belt and suspenders type deal.
Yeah. You typically want to restore the function of the brevis. That's the eversion. That's the dynamic stabilizer of the ankle. you don't really care much about the peroneus longus, so you only replace the brevis. The other question is MRI versus CT for osteochondral lesions. When do you pick when and which?
I mean, I would say you're more than likely going to go off MRI first if you think that based off an MRI you have an intact cartilage cap and it looks like there's some significant bone loss. Is when you may want to get a CT to back you up, certainly if you're going to plan for retrograde drilling or some kind of filling of that defect. So.
All right. I think that's it for the questions. We are going to hand it over for, last but not least, Sarah.
All right. Good evening, guys. Thank y'all for bearing with us. I know this is quite the tour de force as far as content goes to prepare you for a test that always seems to sneak up on all of us much quicker than we ever expected as residents. As I was said earlier, I'm from New Orleans, and I'm going to do a review of several topics this evening with you guys to prepare you for the OICE. Nothing to disclose, just a roadmap to our evening. We're going to talk about posterior tibial tendon dysfunction, which recently has been renamed adult-acquired flat-foot deformity. We're going to talk about Achilles disorders, both ruptures and tendinosis. We're going to cover some muscle forces and biomechanics of the foot, pertinent to some questions that you may get answered. We're going to cover orthotics. And then last but not least, a bear of a topic, but we'll try to keep it short and sweet for diabetic foot and Charcot-neuroarthropathy. Starting with posterior tibial tendon dysfunction or adult-acquired flat foot. Important biomechanics that you need to know and these get tested every year is what does the posterior tibial tendon do? It initiates hindfoot inversion. By initiating hindfoot inversion, it takes your hindfoot from having these flexible parallel joints to being divergent rigid joints. When that happens, that gives you the rigid lever arm that you need to perform a toe-off stance. And so it's what gives you that lever arm to propel yourself forward. Then when you go into heel strike, the posterior tibial tendon relaxes, which gives you your supple hindfoot, which is important for shock absorption. When you're getting questions about flat foot and posterior tibial dysfunction and how to treat it, like all things in orthopedics, don't treat things that don't hurt and don't do surgery on things that haven't tried conservative treatment. First, conservative treatment for these involves physical therapy. Orthotics, we'll cover that later. And don't pick surgery when they don't tell you that the above haven't been tried. I recommend taking a screenshot of this and working through it from memory. This has been modified and modified and modified by us. It's been lots of hours of meetings talking about it, but for the purpose of the test, this is your Bible for understanding a question. And really the most important differentiator that you're going to make when you are answering questions on the test is it flexible or is it rigid? When they're giving you a question stem that points you to a flexible deformity, you're going to think about joint sparing surgery. When they're giving you a question stem where they're talking about a rigid fixed deformity, you're going to think about joint sacrificing surgery. Another nuance, and this kind of goes with that whole, we talk about this for hours at meetings, is that not every flat foot is posterior tibial tendon dysfunction. So don't think that the flat foot stem is pointing you to that algorithm that I just gave you on the previous question. There's also other reasons you can get a flat foot. You can have midfoot osteoarthritis. You can have deltoid insufficiency, so it's more of an ankle problem. So be careful when following the algorithm that I gave you for these atypical flat feet. That I have seen starting to show up on some of the test questions as we were preparing for this talk. Another thing I want to do with you guys is kind of trying to highlight some test taking pros. Now, the OICE does tend to give residents enough time to take the test, but still being able to be an efficient test taker is an important strategy. So reading this question stem, highlighting that this is a flat foot of 2 years. She has medial ankle pain and swelling. She has posterior calf achiness with prolonged walking. What are the pathomechanics of her discomfort? So they're talking about a flat foot. They're talking about calf fatigue. Why is her calf fatiguing? Her calf is fatiguing because her posterior tibial tendon is not locking her hindfoot, so her calf is not being very efficient. So the correct answer here is the posterior tibial tendon is not working, which is causing an inability to lock the transverse tarsal joints to give her that efficient lever arm that allows her to propel forward. Next question. Got some radiographs here of a patient that's tried lots of non-operative things for a fixed, moderate to severe planovalgus deformity. But in addition to addressing their gastroc soleus and fracture, what is the most appropriate surgical approach? So they've just given you the word fixed, i.e. rigid. So anything that is not a fusion, you're going to automatically cross out. So options 1 and 2 and 3 are all osteotomy-based surgery. So the only fusion option that they're giving you is number 4. So that points you to the correct answer there. So you don't even have to read this huge long question. You just see fixed deformity, planovalgus, and you're going to pick the fusion option. Next, we've got a bunch of images that are being shown of a woman that presents a 2-year history of foot pain with progressive flattening of her arch. However, she's got an ability to fire her posterior tibialis. She can't do the heel raise, but she can generate active inversion strength. And then they're telling you this neutral with the knee extended and the hindfoot corrected, but improved past neutral with knee flexion. That is called the Silver Field test. So I included this question so that we could talk about, one, some atypical variants of a flat foot, but also to talk about this nuance of the flat foot examination. So the Silver Field test tells you that there's a gastroc contracture. So when the knee is straight and they don't have a lot of dorsiflexion, and then when you bend the knee and they gain dorsiflexion, that tells you their tightness is coming from their gastroc. When the tightness is coming from the gastroc, you lengthen the gastroc. When the tightness is coming from the Achilles, you lengthen the Achilles. So just with that part of your stem alone, you're able to eliminate answers that have tendo-Achilles lengthening. And then they're giving you an x-ray. They're giving you a lateral x-ray that shows a pretty normal talonavicular joint, but they're giving you also some x-rays that show pretty significant midfoot collapse with tarsometatarsal arthritis. So this is that question I was telling you to be careful about with following the algorithm for an atypical flat foot. This is midfoot arthritis flat foot, not posterior tibial tendon flat foot. So your correct answer here is midfoot arthrodesis and gastroc recession. We eliminated the tendo-Achilles one, and then we eliminated the tendon transfer one because they were telling me that the posterior tibial tendon's working fine. Next, we're dealing with someone who's tried conservative treatment for 7 months with a passively correctable deformity. They're giving you some x-rays that show a lot of talar uncoverage. They're showing you a really collapsed TN joint, but they're telling you it's passively correctable. They're showing you a very crummy looking posterior tibial tendon. So the correct answer here is a joint sparing surgery. Joint sparing surgeries involve corrective osteotomies and a tendon transfer. Next, we already saw this question asked in Dr. Eba's presentation, but just again to highlight question taking strategies. Chronic medial ankle pain, flexible flat foot, able to generate intact posterior tibial tendon function with painless inversion. And they're showing you an ankle x-ray with a valgus deformity, but a pretty normal looking foot. So you're not going to do stuff to a normal looking flexible foot. You're going to do stuff to the pathologic deformity. And in that case, that's again, ankle arthroplasty to treat their valgus ankle arthritis. Next, we're going to transition into Achilles disorders. We're going to talk about both rupture and tendinosis. When you're talking about rupture, the big thing that they are going to look for is differentiating between non-operative and operative treatment. They're not going to ask you which is better, because there's studies that say both. For non-operative, there's a bunch of protocols. For operative, there's lots of techniques. They're not going to ask you about those. Honestly, the biggest indication for choosing is patient choice. You're going to favor non-operative treatment in someone who's a poor surgical candidate, and you're going to favor operative treatment in someone that has a chronic care, because that gap's not going to be filled out of nowhere. Downsides to non-operative treatment, especially the one they like to test, is that some studies have shown an increased re-rupture rate. And functionally speaking, there are very strict diagnostic criteria to be a participant in these treatment protocols. The buzzword, if you see a question stem that's pointing you towards non-operative treatment and they say, what is the preferred treatment protocol? Functional rehab. It's an early weight-bearing type of protocol that has been shown to improve those re-rupture rates that we're seeing in days gone by when we casted these people for a long time. Operative treatment, again, chronic care, you need to fill the gap. That gap's not going to fill itself with non-operative treatment. The downside to it is wound complications. That's where patient selection is so important. I did see some questions about this. So when we're talking about the gap in the chronic tears, when to pick what answer, generally if the gap is less than 2 centimeters, sorry, I left off my unit, you're going to do an end-to-end repair and just put the foot in plantar flexion to bridge that gap. When the gap's somewhere between 2 and 3, 2 to 4, you're going to do a VY lengthening. And when the gap is big, somewhere bigger than 3 or 4, you're going to do what's called a turn down procedure. If you ever see someone is trying to point you to allograft, only pick the allograft answer if it's a salvage or revision situation. You're always going to pick using their own biology first. Achilles tendinopathy, what's the buzzword? Again, don't operate on things that haven't tried conservative treatment. Conservative treatment here is eccentric stretching. Operatives should be considered after 3 to 6 months above by treatment. You treat the pathology. There's lots of different techniques. Read the question stems, see where they're pointing you. The big things that might be tested though is if you're doing a tendon debridement and you have to debride more than 50% of the FHL. I'm sorry, you have to be more than 50% of the tendon, you're going to do an FHL transfer. Note though that that does not weaken plantar flexion of the foot, and it does not weaken plantar flexion of the great toe. In some studies, even it improves your plantar flexion strength. Just a note on anatomy, when you're doing your bumpectomy of the calcaneus for insertional Achilles tendinopathy, there's really 2 bumps. One is your Haglund bump, that's the squared tuberosity. The second is your cuspicic Achilles. And so there's 2 bumps that need to be addressed, and they may circle one or the other and ask you about their origin. All right, transitioning into questions. So during surgical repair of this pathology shown on the bottom right, what outcome can be expected when including an FHL transfer rather than just debriding the tendon and repairing it? Seen equal outcomes. So VAS scores, not different. And then, like I said, it doesn't decrease your plantar flexion strength and it doesn't improve your clinical outcomes. So where they're pointing you here is you're actually adding strength to a very weak Achilles. And so by adding strength from plantar flexion to a very weak Achilles, you're improving your plantar flexion strength of your ankle. Figures 1 and 2 are an MRI image of a patient that reports pain along her Achilles for several months. She's tried a host of non-operative treatment. After failure of that non-operative treatment, she goes to surgery. There's a gap in her tendon that's measured just under 2 centimeters. In addition to maybe considering an FHL transfer, what is the most appropriate reconstructive procedure? So you've got an MRI that shows it's not that far apart already before you in surgery, and they even tell you less than 2 centimeters. So you're going to pick the direct end-to-end repair. Next, they're telling you about a 45-year-old basketball referee who's got 6 weeks of pain and a fusiform mass in the mid-substance of the Achilles. What is the effective treatment? So 6 weeks of symptoms, painful Achilles. You're not going to pick surgery. You're never going to pick steroid going around your Achilles. You're going to do an eccentric strengthening exercises to work on that Achilles flexibility and promote collagen reorganization. Next, they're giving you a question stem of someone who sustained a laceration to their ankle 3 months ago. They were washed out in the ED and put in a boot and haven't had any treatment since. They have increased passive dorsiflexion, basically telling you that there's increased resting length to their Achilles, and they have weakness. The wound is healed. What's the next step? They give you all these pictures, but the most important pictures are those in the middle that are showing you a big old gap in the Achilles, but doesn't look like much tendon. So they're telling you gap. So the gap and chronic repair is not going to be amenable to a percutaneous repair. Gap and chronic is not going to be amenable to an end-to-end repair. Gap and no prior surgery is not going to be filled with an allograft. That's for revision setting. So the only answer here that makes sense is a turn-down procedure and FHL transfer to bridge that gap. Next, we're moving on to muscle forces and biomechanics in the foot. Really, the place where this is the most pertinent is when we talk about pes cavus and Charcot-Marie-Tooth disease. So understanding what goes on in pes cavus. You have a weak peroneus brevis. That's the basis of it. So any form of pes cavus, whether it's subtle cavovarus all the way through Charcot-Marie-Tooth, at its root is a weak peroneus brevis. So by weak peroneus brevis, there's not as much active eversion of the foot. And so the foot falls into a varus resting position. When the foot's sitting in that varus resting position, you're overloading the lateral column. You then also have an overactive peroneus longus. That plantar flexes the first met. With that plantar flex first met, as you can kind of see in this pictogram I tried to make here, with that plantar flex first met, that's pushing down here at the ground, And so that again shifts you onto the lateral border of your foot, and then you end up with hindfoot varus. What happens when you start talking about Charcot-Marie-Tooth? You have these things above that I just talked about, but you also have a motor sensory neuropathy. So you get those dominant forces of the peroneus longus mixed with a tibialis anterior that doesn't work. So you also see foot drop, and you have foot intrinsic weakness, so you see claw toes. When these patients present, you often see cavovarus, but it can be forefoot driven, hindfoot driven. It can be primarily hindfoot varus. What are you looking for when you see these patients? So when you're looking at cavus, they have a plantar flex first ray, which drives them into lateral column overload. With that lateral column overload in that cavus, you often see peroneus longus pathology. And then you see this increased calcaneal pitch. So you see this calcaneus that starts to point more towards the sky. Varus, what happens to people in varus? They often have recurrent sprains because they twist their ankle. They have a stiff hindfoot. Why is that hindfoot stiff? Hindfoot stiff because in this pictogram we talked about here, we said when your hindfoot's inverted, it's rigid. That's that locked posterior tibial tendon that drives you, that gives you that rigid lever arm. So if you have someone that's stuck in varus, they also have a stiff hindfoot, so they can't accommodate the ground well. The other thing you see is when they stand and face, you see this peekaboo heel sign. The test question that they're going to bring up when you're evaluating someone with a cavovarus foot is the Coleman block test. The Coleman block test is useful for identifying is it flexible versus rigid, and then is it forefoot versus hindfoot driven. So this is how you do the test. You put a block under the lateral border of the foot. By putting a block under the lateral border of the foot, if they have forefoot driven cavovarus, that allows that first ray, the plantar flex, and then their hindfoot goes from this varus into neutral alignment. That tells you it's forefoot driven and flexible. If they don't correct, that tells you that it is rigid or hindfoot driven. And so you see this correction of their peekaboo heel when you elevate the lateral border of the foot. All right, moving on. We've already kind of covered ankle arthrodesis and ideal positions, but just again, kind of some of the biomechanics there. You want a little bit of valgus, because valgus helps with shock absorption. Varus makes your hindfoot rigid. You want a little external rotation that helps you with ground clearance since you don't have as much active dorsiflexion. You want a little posterior translation because that helps with shortening your lever arm of your foot. And then last, you want neutral dorsiflexion because if you have equinus, as we saw in the question that Dr. Eba presented, you otherwise have to accommodate to that with knee hyperextension. Using your big toe joint, this famous Australian tennis player had it and is able to continue playing sports, but what position allowed him to do that? With regard to dorsiflexion, you want 25 to 30 degrees off of the first metatarsal. And what happens if you don't obey that principle? If you over plantar flex it, you end up getting that head overload. If you over dorsiflex it, then that big toe claws down so that you can still recruit to the ground because the big toe isn't there. You also don't want to create the Michael Strahan effect in your toes. You don't want a big old gap. You actually do want a little bit of valgus when you use this. So what minor toe deformity is most likely associated with an underlying neurologic condition? Neurologic condition, Charcot-Marie-Tooth, claw toe deformity. Next, this is that question we saw Dr. Eva present. So this is the gentleman who had an ankle arthrodesis several years ago, and you notice that he back knees or hyperextends during gait. That's because he's in a bunch of equinus or plantar flexion. Next, they tell you that this patient with these crazy looking x-rays, really high scalp pitch, dry through sign of the sinus tarsi, really high talus metatarsal angle, and they even tell you Charcot-Marie-Tooth. So what happens in Charcot-Marie-Tooth? The overarching thing is the peroneus longus dominates. You got to look for something where it says peroneus longus dominates. Wherever the peroneus longus is overpowered, that's not right. And then also you know that the tibant is weak. And so what you want to look for here is peroneus longus overpowers tibialis anterior is the main driver. So peroneus longus dominates in cavovarus deformity. Next, again, kind of as we talked about, sometimes they don't give us the best pictures for this, but the important thing is look for what the answers they're giving you and look for what might have fluid around it. Look for something that might have some splits in it. They're going to still make it. So this is showing you some cross-sectional imaging on MRI, and they're showing you some fluid around the tendon. That fluid is here. So then you go to your cross-sectional anatomy. Okay, what is this? This is the posterior tibial tendon. So when is the posterior tibial tendon important? It's important as you go into terminal stance, as you're about to go into heel rise, because you got to lock that hind foot before you go there. Next, orthotics. So we talked about some of these deformities. Now we're going to talk about some of the nuances of the non-operative treatment and how to pick the right orthotic on the test. If they're giving you a question stem that's a Cadis foot, you're going to do a lateral posted orthotic. So you're going to mimic that Coleman block test. That by posting that lateral column, you let the first met fall into this release, and that helps support the pes cavus foot. Pes planus or acquired flat foot deformity. If they're flexible, you're going to do a medial posted orthotic or this orthotic called a UCBL that kind of controls that flexible hind foot and helps promote it into a more neutral position rather than falling into that plantar valgus. If they have a rigid deformity, you're going to pick a brace like an Arizona gauntlet. Plantar fasciitis. Note, answer is never custom orthotic or plantar fasciitis. You're going to use a night splint at night to stretch out that plantar fascia. You're going to use over-the-counter gel cushions or arch bands to support plantar fasciitis. You're not going to choose surgery for plantar fasciitis, and you're not going to choose custom orthotics. Hallux rigidus. We kind of talked about this a little earlier, but you're going to use a Morton's extension, which is basically a carbon fiber plate that stiffens up the shoe. By stiffening up the shoe, you don't flex through that painful great toe joint. When you are an amputee and how much energy it takes to walk, just some numbers kind of for rote memorization. If you're up a below knee, 25%. Bilateral, depends on whose study you read, but bilateral is generally a double effect, if not a plus effect, depends on whose study you read. If you're an above knee amputation, it's highly energy consuming to ambulate. All right, 65-year-old woman treated for years for presumed plantar fasciitis, but only gets short-term relief. She's got tenderness in the center of her heel pain, no pain with compression of the heel, i.e. negative calf squeeze, negative calf stress fracture, and she's not particularly tender over the abductor calluses, so she's not having any of that back neuritis type stuff. What is the most appropriate treatment option for her? So plantar fasciitis, not going to pick surgery. Plantar fasciitis, not going to immobilize them for a long period of time. So you're going to do shoe wear modifications. Next, they're giving you a question stem that says someone with 8 months of history with pain along the lateral midfoot and peroneal tendons. So they're kind of trying to point you towards that cavovarus foot with the lateral column overload. What do you pick for a cavovarus foot? Well, carbon fibers for arthritis. University of California, Berkeley Laboratories is that UCBL for flat foot. Full-length steel shank is something we usually use for diabetics. Full-length semi-rigid insert with arch support and medial post, that's for a flat foot. So last but not least, full-length insert with first metatarsal head recess and a lateral heel/sole wedge. Next, this is just a rote memorization thing. Patients undergo a transtibial amputation must exert which percentage of increased energy for ambulation? You've got to know this, 25%. Last but not least, diabetic neuropathy and Charcot. All right, so when you see someone with a metatarsal head ulcer, you're first going to pick wound care and total contact casting. If they failed that, you're going to do a gastroc or tendo-Achilles lengthening that decreases ulcer recurrence, but you're still going to do wound care and total contact casting. When you see someone with a midfoot rocker, usually as a result of Charcot, you're going to again do wound care, total contact casting. When you get their wound to heal, you're going to get depth, rocker sole, plus minus that steel shank, and a full-length accommodated insert. When that's not successful, the answer is a tendo-Achilles lengthening and either an exostectomy or a tendo-Achilles lengthening and recon. They'll give you things in the stem that point you to one or the other. It'll usually be something about the patient's risk factors, something like that, but you're either going to pick the recon or the exostectomy, but it's always going to be with a TAL. When to operate in general on Charcot or on diabetics is when wound care and casting fails, when there's impending ulceration, when they don't have a shoeable foot, or when they have active infection that needs to be treated. Fracture fixation. There's different ways we take care of fractures in the neuropathic. So they're going to give you a question stem that points you to thinking someone's neuropathic, the painless dislocation or the delayed presentation to the ER. Just because a patient has diabetes, even if it's poorly controlled, does not mean you don't fix them, but you fix them different, and it's important that you fix them right. The concept and way I was taught it is rigid and robust fixation. So you double the strength of your fixation, as you can see here, with multiple traversing syndesmotic screws. You double your duration of immobilization, and you never use anything flexible. So finishing up here, we're going to go into some questions STEM here. We're giving you a non-healing ulcer, a poorly controlled diabetic with an A1C of 8.2, and what patient characteristics signals the failure of transmetatarsal amputation. Biggest thing that signals their failure is that elevated A1C. They're not a current smoker. They said current smoker would be different, but they said former smoker. Next question. They're giving you radiographs, really unimportant, because all you need to read is plantar ulcer in the region of the first metatarsal head, and they're saying that they've tried a bunch of treatment. There's no exposed bone. What intervention will allow for ulcer healing and decrease risk of recurrence and maintain function? The answer here is tendo-Achilles lengthening, because it offloads that for plantar forefoot. Next, they're giving you another person with a non-healing wound. This time it's a neuropathic heel ulcer that does probe the bone. They've tried serial debridement, they've tried wound care, they've tried all the things. They're not sick, and they've not had a change in their insulin factor, so they're trying to say they're not septic. What is the most appropriate treatment of this? And so what they're trying to point you to is you need to do something to get rid of that bone that's at the base. If you're going to do a calcaneal saucerization, saucerization is a fancy word for exostectomy of the calf, and then you're going to lengthen the Achilles again. So diabetic ulcers that fail conservative treatment, something needs to be done to their posterior structures, whether it's a gastroc lengthening or tendo-Achilles lengthening. All right, rounding it out here, we got a diabetic with peripheral neuropathy who sustained ankle fracture dislocation, fixed 4 weeks ago, and comes in with this X-ray. What would have minimized their risk of this complication? So double the fixation, double the immobilization. So this needed additional internal or external fixation. All right, y'all. Thank you for bearing with us. We got any questions?
Yes, Sarah, we have one.
Okay.
In a question stem, what are you looking for to distinguish flat foot from posterior tib dysfunction versus other causes like midfoot osteoarthritis or deltoid insufficiency?
Great question. So often what they're going to give you in the STEM is they're going to say they still can't do the heel rise because they are flat, but what they're then going to tell you is when they are doing the bench examination and you try to generate power from your posterior tibial tendons, they're going to do that active inversion. They're going to have normal function of the posterior tibial tendon on bench exam, but they're going to have all the other clinical findings on standing exam of being a flat foot. So they're trying to say it's not the posterior tibial tendon, but there's still a flat foot.
I guess we don't have any other questions. I'll give it like a few seconds. We're gonna like have just a couple minutes before we end this.
While we wait for any questions to pop up, I'd like to thank all the residents, and I would tell them that if you're interested, there is a resident scholar program in which the AOFS hosts interested residents who are interested in pursuing foot and ankle career or fellowship. There is a scholarship that would allow you to attend the winter meeting happening at the end of February in Arizona. So I think you're going to see announcements coming up for that to apply. So we encourage all of you looking forward to a foot and ankle fellowship or career to consider this. Finally, this is the CME claim information. You've spent an hour and a half with us, so please go ahead and claim your CME. It's worth it. And if not, I'll hand it over to Dr. Mustafa again.
Well, I guess we've come to the end of tonight's webinar. First, I want to thank all the attendees who stuck with us. Sorry, that was a lot in short time, but we tried to cover a lot of topics, buzzwords. Hopefully that would be helpful in the OITE. I want to thank the AOFAS board and staff for making that happen. I want to thank my co-presenters, Sarah, Pierce, and Laura. You've done an amazing job. Too many topics in short time, so very well done. And with that, I'm going to tell everybody you all have a good night.
Night, y'all.